Okay, let's unpack this. Today, we are undertaking quite a deep, advanced dive into a field that really demands absolute mastery, ischemic heart disease, IHD, and, well, the highly precise pharmacology of antianginal drugs. Our listener really wants to master this, moving beyond just classifying things to understanding the strategic clinical application of these, frankly, life-saving agents.
It is, yeah, it's a profound mission. When we talk about IHD, we are discussing the most common cause of mortality worldwide. So this knowledge isn't just theoretical, it is absolutely foundational medicine. Fundamentally, we're dealing with a crucial imbalance. The heart muscle's demand for oxygen significantly outweighs the supply that's available through the coronary arteries.
That imbalance, that's the core problem, isn't it? Our sources give us the framework for understanding how, fixed atherosclerotic obstructions or increased demand from stress or exercise, and sometimes these dynamic vasospasms, how they all translate into chest pain. And we have these four major drug classes: beta blockers, calcium channel blockers, organic nitrates, and that sodium channel blocker, ranolazine, all basically designed to restore that equilibrium.
Exactly. Our goal today is to connect those dots,
Yeah.
understand the pathology, see how the clinical picture changes, and then precisely match the drug mechanism.
Yeah.
Whether it affects blood pressure, venous return, heart rate, or contractility, match that to the patient's specific needs. So maybe let's start by defining the clinical landscape itself.
Good idea. So the characteristic symptom of this myocardial oxygen deficiency is angina pectoris, and it's often described in, well, quite frightening terms: sudden, severe, crushing chest pain.
And critically, that pain typically originates substernally, but it frequently radiates. And for the professional, recognizing that characteristic pattern is just essential. Radiation to the neck, the jaw, the back, often down the inner aspect of the left arm. This reflects the shared sensory innervation via the C7 to T4 dermatomes.
And the presentation of that pain, how it shows up, that dictates the entire subsequent therapeutic strategy, right?
Yeah.
You mentioned two main mechanical causes underlying this deficiency.
That's right. The first and the most common one is the fixed obstruction due to atherosclerotic lesions, plaque buildup, that simply limits the maximum blood flow capacity. The second is more dynamic. Spasms of the vascular smooth muscle, which actively squeeze the vessel closed, impeding perfusion even if the underlying blockage isn't, let's say, severe.
Okay, so based on those mechanisms and the timing of the pain, let's maybe categorize the three main patterns, starting with the classic one: stable angina.
Right. Stable angina is kind of the baseline, often called effort-induced or typical angina. It's driven by that fixed obstruction from atherosclerosis. So the patient has enough blood flow when they're resting, but when oxygen demand spikes, like during physical exertion, emotional stress, or maybe rapid heart rate increase, those stiffened coronary arteries just can't dilate enough to deliver the extra supply needed.
So the pain is predictable then. It's almost like dose-dependent on activity.
Exactly. It's short-lasting, a burning, heavy, or squeezing feeling, usually lasting only a few minutes. And the clinical hallmark, the thing that makes it stable, is that the pattern is consistent over weeks or months. And crucially, the pain is promptly relieved either by just resting or by taking sublingual nitroglycerin. If that pattern starts changing, well, then you immediately shift your diagnostic suspicion.
Speaking of shifting suspicion, the sources really hammer home the need to look beyond just the classic presentation. We can't assume every patient reads the textbook, can we?
No, absolutely not. This is a vital point, especially in modern practice. Ischemic episodes frequently present, well, atypically. So instead of that crushing pain, you might see profound, uncharacteristic, extreme fatigue, maybe nausea, shortness of breath, or diaphoresis sweating. And these atypical presentations, they're disproportionately common in specific groups: women, the elderly, and critically diabetic patients, where autonomic neuropathy can actually blunt that classic pain response.
And then there's the sort of clinical ghost,
Totally.
silent angina.
Silent angina.
Yes.
Yeah. Perhaps the most dangerous because the episodes are entirely asymptomatic, yet the underlying cardiac damage and stress are still happening. Detecting these often relies on things like stress testing or continuous ECG monitoring, which really underscores that we can't just rely on symptom management alone.
Okay, let's pivot now to the dynamic, less common type, Prinzmetal angina. This pathology sounds fundamentally different, driven purely by a failure in supply.
Prinzmetal or variant angina, yeah, it's fascinating. It's caused by a transient, severe spasm of the coronary arteries, leading to these profound, but usually brief, drops in blood flow. The defining feature is that it happens at rest. Often these attacks tend to cluster in the early morning hours, which seems to correlate with natural circadian surges in things like catecholamines and vascular tone.
And the key distinction is that these attacks are unrelated to exertion, heart rate, or blood pressure changes. The spasm itself is the primary issue, even if there's some underlying plaque.
Yes, exactly. And because the mechanism is this dynamic vascular constriction, the treatment response is also distinct. It responds beautifully and promptly to agents that promote rapid vasodilation, namely nitroglycerin and calcium channel blockers. This is a critical factor when you're selecting the initial therapy.
Okay, that really sets up the third and most clinically urgent category, unstable angina. This sounds like where the fixed plaque, the demand, and maybe even spasm all start to converge into a real emergency.
Unstable angina, or UA, it signals impending myocardial necrosis. It's defined by a change in that stable pattern. Pain that increases dramatically in frequency, duration, intensity, and it's precipitated by progressively less effort. The alarm bells really ring when we see rest angina lasting longer than, say, 20 minutes, or when new-onset angina is severe and limiting. We sometimes call this crescendo angina.
And the defining clinical feature that elevates it to an emergency is that the symptoms are not reliably relieved by rest or sublingual nitroglycerin anymore.
That shift demands immediate action.
Yeah.
UA is classified as one form of acute coronary syndrome, or ACS, and it necessitates urgent hospitalization and, well, aggressive intervention.
If we dig a bit deeper into that ACS mechanism, how does UA actually differ from a full-blown myocardial infarction and MI?
Well, the transition from a stable plaque to ACS usually involves the plaque rupturing. The fibrous cap covering the atherosclerotic lesion tears open, exposing the thrombogenic material inside to the bloodstream. Platelets rapidly aggregate, triggering the coagulation cascade, and you get a thrombus forming. In UA, that thrombus is typically non-occlusive. It partially blocks the vessel, causing severe ischemia, but not yet full necrosis or cell death.
Ah, okay. And that leads us to the crucial diagnostic split, usually in the emergency room setting.
Precisely. If that thrombus persists and leads to cardiac muscle cell death, that's necrosis, we call it a myocardial infarction. We confirm necrosis by looking for elevated serum biomarkers, primarily cardiac troponins, IRT, and historically we also use creatine kinase isoenzymes, CKMB.
So the textbook difference that the elite professional hold on to is patient presents with rest angina, the ECG looks concerning, but the biomarkers of myocardial necrosis, those troponins, are not elevated. That's unstable angina.
Correct. If the biomarkers are elevated, this syndrome has progressed to MI. Clinically, we then divide MI into NSTEMI, non-segment elevation MI, usually meaning partial occlusion still, and STEMI, ST segment elevation MI, which usually indicates a complete acute occlusion. Understanding this distinction rapidly determines the need for immediate reperfusion therapies like percutaneous coronary intervention, PCI, or thrombolysis. These are essential for NSTEMI and STEMI, but often delayed until stabilization in unstable angina itself.
Got it. That distinction is critical for immediate management. So understanding that whole spectrum of disease brings us squarely to intervention. We're trying to solve that supply-demand mismatch, and our sources outline the 4 major pharmacological tools we have.
Yeah, and every single agent we discuss, from the oldest nitrate to the newest sodium blocker, is aimed at manipulating that central equation via 4 key hemodynamic levers. Decreasing blood pressure, that's afterload, decreasing venous return, preload, decreasing heart rate, and decreasing contractility. Pulling any of these levers generally decreases the heart's oxygen demand.
But before we jump into the specific drugs, we absolutely have to address the foundational mandate, right? Medication isn't the first or only step.
Absolutely not. The non-pharmacologic mandate is paramount. Every patient diagnosed with IHD or any form of angina must immediately initiate what we call guideline-directed medical therapy, GDMT. This focuses heavily on aggressive modification of risk factors. We're talking mandatory smoking cessation, structured physical activity, weight management, and intensive control of comorbidities like hypertension, hyperlipidemia, which almost always requires statins, and diabetes. This is what provides that long-term reduction in morbidity and mortality.
And for acute symptomatic relief, the go-to remains the same.
Yes, the standard remains sublingual nitroglycerin. Every patient needs to be counseled on how to use the tablet or spray for prompt relief of an acute attack. Its rapid onset, usually within 1 to 3 minutes, makes it indispensable for symptom management and also for helping triage whether the pain is stable or potentially unstable.
Okay, now let's map out that stepwise approach for managing chronic, stable angina, the algorithm that really defines modern practice. Where do we start therapy?
Step 1, the first-line choice, is initiating VUL blockers. They are the initial antianginal therapy of choice unless there are clear contraindications. The goal is usually to titrate the dose upwards until you reach a target heart rate, often around 55-60 beats per minute at rest, or until side effects limit further increases. Their selection is primarily driven by their proven ability to reduce cardiac workload and demand.
Why vol blockers first rather than, say, a nitrate or a CCB?
It largely comes down to the long-term mortality data.
Yeah.
In patients who've had a prior MI or who have heart failure with reduced ejection fraction, vol blockers provide a distinct survival advantage that the other antianginal agents don't necessarily share. So they're symptom managers, yes, but with a proven mortality benefit in those specific high-risk groups.
Okay, so if we maximize the vol blocker dose, push it as high as tolerated, and the patient is still symptomatic, what's next?
Then we move to step 2, combination therapy. We add a second agent. This is typically either a calcium channel blocker or a long-acting nitrate. The choice between those two often depends on the patient's existing hemodynamics. Do they need more blood pressure control? Maybe favor a CCB. Do they have significant issues with preload? Maybe a nitrate is better. Or remember, if they have Prinzmetal angina, we'd likely skip the butt blocker entirely and start with a CCB and/or a nitrate right from the beginning.
And what if we have a really challenging case, what we call refractory angina, despite having two agents maximized?
That brings us to step 3. We add ranolazine. Ranolazine is generally reserved for those patients who have failed the traditional pairings. Its main appeal here is that it provides anti-anginal relief without significantly lowering heart rate or blood pressure further. This lets us augment therapy without incurring unacceptable hemodynamic risks, like severe bradycardia or hypertension, which could happen if you piled on 3 traditional demand-reducing agents.
This systematic approach sounds great, but it has to be customized, doesn't it? The sources spend a lot of time detailing how coexisting diseases force us to tailor the drug choice. This seems like where the elite professional really differentiates themselves.
Absolutely.
Hmm.
Think about the patient with a recent MI. As we mentioned, the mandate there is A blockers, probably combined with a long-acting nitrate or maybe a CA2 plus channel blocker. Why? Because those MA blockers actively reduce the risk of sudden death and recurrent MI by mitigating things like adverse cardiac remodeling and sympathetic overdrive post-MI.
Okay, what about a patient with a respiratory issue like severe asthma or maybe COPD?
That definitely introduces a significant constraint on Bob selection. We have to strictly avoid non-selective blockers like propranolol in asthma because blocking O2 receptors in the bronchi can trigger dangerous bronchospasm. So in that case, we'd likely default to a long-acting nitrate or a CA2 plus channel blocker. If a Bob blocker absolutely must be used in a COPD patient, we choose a highly cardioselective agent like metoprolol, start low, go slow, and monitor their lung function very closely, always remembering that even selectivity can be lost at higher doses.
Let's tackle the really common scenario. Managing IHD in someone who also has hypertension, but maybe their heart rate is already on the low side.
Yes, this requires surgical precision almost.
Yeah.
We're often managing hypertension, diabetes, and IHD all at once. So in a patient with uncontrolled high blood pressure, but who already has symptomatic bradycardia, say, a resting heart rate of 50, you absolutely must avoid agents with strong negative chronotropic or inotropic effects, things that slow the heart down or weaken its pump.
So verapamil or metoprolol would be pretty risky choices there.
Highly risky. They would likely worsen the bradycardia, potentially leading to symptoms like dizziness, syncope, or even heart block. In that specific scenario, amlodipine, which is a dihydropyridine CO2 plus channel blocker, is strongly preferred. Amlodipine is a potent vasodilator, so it controls blood pressure by reducing afterload, but it has a minimal effect on cardiac conduction. It preserves that low heart rate. This contrasts metoprolol verapamil as rate reducers versus amlodipine as a pure vasodilator is a really critical decision point when you're tailoring therapy.
Okay, let's go deep now into these workhorse classes, starting with beta blockers. We know they're first line, but let's really solidify their mechanism for reducing that oxygen demand.
Right. Their mechanism targets the heart's machinery directly. By blocking the ORA1 adrenergic receptors, primarily located in the myocardium, we essentially dampen sympathetic stimulation to the heart. This achieves that triple objective. Reduced heart rate, that's negative chronotropy, reduced force of contraction, negative inotropy, and by reducing cardiac output, it also leads to a reduction in blood pressure. The cumulative effect is a profound reduction in myocardial oxygen consumption, both during rest and during exertion. And that's why they reduce both the frequency and severity of stable angina attacks. They literally shift the ischemic threshold, letting the patient do more before pain kicks in.
That sounds like a pretty universal solution, yet we have that critical exception. Prinzmetal angina. Why are they ineffective or maybe even detrimental in vasospasm?
Yeah, this is a fundamental concept to grasp. In vasospastic angina, the main issue isn't primarily demand. It's an acute supply failure because of the spasm. Vi blockers don't really address smooth muscle spasm. Furthermore, if you use a non-selective agent, blocking the E2 receptors, which are also present in coronary arteries, prevents any potential compensatory vasodilation. Even worse, blocking B2 leaves the alpha adrenergic receptors unopposed. Alpha receptors mediate vasoconstriction. So blocking B2 can actually potentiate vasoconstriction via unopposed alpha stimulation, potentially exacerbating the coronary spasm and worsening the attack. It's counterproductive.
That makes perfect sense. You're essentially removing the body's natural brakes on constriction in that specific context. You mentioned ISA agents earlier. Why must agents with intrinsic sympathomimetic activity, ISA, like Pindolol, be strictly avoided?
ISA agents. They're often described as partial agonists. So they block the effect of high levels of endogenous catecholamines, like adrenaline, but they also maintain a low level of sympathetic activity themselves. Now, while this might sound appealing because it results in less resting bradycardia compared to pure antagonists, it completely undermines the goal of maximal cardioprotection in IHD. They just don't confer the same magnitude of long-term mortality benefit that we see with pure antagonists, likely because they don't fully block that harmful sympathetic overdrive, especially post-MI.
Got it. Let's touch on selectivity again. We generally prefer metoprolol or atomol, the cardioselective ones, over something like propranolol, the non-selective prototype.
We aim for cardioselectivity, meaning preferential VAD-AM blockade, primarily to minimize peripheral adverse effects. Things like bronchospasm, which is a BETI2 effect, or maybe excessive peripheral vasoconstriction. Propranolol is non-selective, hitting Getty and BOT2 equally, impacting lungs, vasculature, and metabolic processes. But the caveat, always, is that selectivity is dose-dependent. At high enough doses, even metoprolol will start to inhibit PAIR2 receptors. That's why a history of severe asthma is generally considered a hard contraindication for all blockers, regardless of selectivity.
Okay. And finally, let's really examine that tapering rule. We have to counsel patients intensely about not stopping abruptly. Why does the heart react so violently?
This is all about receptor upregulation. When you chronically block DABA receptors over time, the body senses this blockade and compensates by synthesizing more receptor sites on the cell surface. It becomes supersensitive. If you then suddenly withdraw the medication, all those highly sensitive, newly manufactured receptors are suddenly exposed to the patient's normal circulating catecholamines. This causes a massive, unchecked sympathetic surge, which can lead to rebound angina, severe hypertension, and tragically can even precipitate an acute MI or a lethal arrhythmia. This is why gradual tapering over 2 to 3 weeks is absolutely mandatory.
A truly critical clinical point. Okay, let's move to the second pillar, calcium channel blockers, CCBs. They seem to address the supply-demand balance from a completely different angle, involving ion fluxes.
Yeah, the mechanism here is quite elegant, actually. In ischemic tissue, cells become a bit leaky and depolarized, leading to an unwanted excessive influx of calcium ions into the cell. This calcium surge triggers ATP-consuming enzymes, accelerating the depletion of precious energy stores and further damaging the cells. CCBs work by inhibiting the L-type voltage-gated calcium channels, effectively limiting this damaging influx of calcium.
And the net result is muscle relaxation.
Yes. All CCBs are potent arteriolar vasodilators. They decrease smooth muscle tone and vascular resistance. This means they reduce systemic vascular resistance, what we call the afterload, the resistance the heart pumps against. By reducing that afterload, they decrease myocardial oxygen consumption, making them highly effective in effort-induced angina. And, of course, their ability to relax coronary arteries, smooth muscle directly, is why they are so valuable in vasospastic angina.
But we absolutely must master the differences within the CCB class itself. Let's start with the dihydropyridines, the pines, like amlodipine, nifedipine, felodipine.
The dihydropyridines, yes. Think of them as the workhorses of the vasculature. They primarily target peripheral and coronary arteriolar smooth muscle. They're characterized by having minimal effect on cardiac conduction, so they don't significantly slow the heart rate. This makes them poor choices if you need rate control, but excellent choices for reducing afterload and blood pressure. Amlodipine in particular has become a real staple due to its long half-life and potent vasodilatory effect. It's superb for managing both hypertension and variant angina because of that direct antispasm effect.
But the sources issue a really serious, non-negotiable warning about short-acting formulations of these.
Yes, absolutely. The warning specifically concerns short-acting dihydropyridines, most notably immediate-release nifedipine. These agents cause a very rapid, often precipitous drop in systemic blood pressure. The body recognizes this sudden hypotension as a crisis and compensates by releasing a massive surge of catecholamines, resulting in what we call reflex tachycardia, or rapid spike in heart rate.
Why is that reflex tachycardia so dangerous in a patient with known coronary artery disease?
Because it sharply increases myocardial oxygen demand. At the very moment when the patient's compromised coronary arteries cannot possibly increase supply to meet it. This creates a severe demand-supply mismatch, and there's actually evidence linking these short-acting formulations to increased mortality after MI and an increased risk of acute MI in hypertensive patients taking them. So for stable CAD, long-acting formulations are definitely the standard of care.
Okay, really important distinction. Now let's move to the non-dihydropyridines, verapamil and diltiazem. Their primary action sounds like it involves both the vasculature and the heart's conduction system.
Exactly. They're the dual-action agents. They slow AV nodal conduction, they decrease the sinus node firing rate, so they slow the heart rate, and they also exhibit negative inotropic effects, meaning they decrease the force of heart muscle contraction. All of this translates directly into reduced heart rate and reduced oxygen demand.
Let's try to nail down the critical gradient of activity between them for clinical decision-making. How do verapamil and diltiazem differ from each other and from amlodipine?
Okay, if you imagine a spectrum, amlodipine is almost entirely focused on the vasculature, very little effect on the heart itself. At the other end of the spectrum is verapamil. Verapamil has the greatest negative inotropic effect. It affects myocardial contractility and conduction the most, and it's the weakest peripheral vasodilator of the group. Diltiazem sits nicely in the middle. It offers effective slowing of AV conduction and heart rate, but it also provides good coronary artery vasodilation. This makes it a very balanced agent, often useful for variant angina or chronic stable angina, where you need some rate control, but maybe a blocker is contraindicated or not tolerated.
We absolutely have to reiterate that final critical contraindication, combining a non-dihydropyridine CCBs, especially verapamil, with heart failure.
It is an absolute contraindication. Because of their inherent negative inotropic effects, verapamil and diltiazem will suppress contractility, directly worsening symptoms and outcomes in patients with heart failure, particularly those with a reduced ejection fraction. Verapamil is also specifically contraindicated if there are any existing AV conduction abnormalities, like heart block, because of its potent slowing effect on the AV node. You just don't want to risk making things worse.
All right, let's turn to the organic nitrates. These sound effective across the entire angina spectrum, stable, unstable, and variant. The key seems to be their conversion to nitric oxide.
The molecular mechanism is, well, it's truly a masterpiece of pharmacology. Nitrates are essentially prodrugs. Once they get inside the vascular smooth muscle cell, they're converted, often by an enzyme called mitochondrial aldehyde dehydrogenase, into nitric oxide, or NO. And NO itself is an incredibly potent signaling molecule.
What does the NO actually trigger inside the cell?
So NO immediately activates an enzyme called guanylate cyclase. Granulate cyclase then increases the synthesis of cyclic guanosine monophosphate, or CGMP. The rise in CGMP acts as a second messenger, triggering a cascade that ultimately leads to the dephosphorylation of the myosin light chain in the muscle fiber. When that myosin light chain is dephosphorylated, the muscle fibers relax. Smooth muscle relaxation.
And this relaxation delivers that dual therapeutic effect we talked about earlier, hitting both preload and maybe supply.
It does. The primary effect, and arguably the most important for angina relief, is the massive dilation of the large veins. This pools blood peripherally, significantly reducing the amount of blood returning to the heart that's reducing preload. Reducing preload dramatically decreases the workload and oxygen demand of the heart. The secondary benefit is the dilation of the coronary vasculature itself, which can help increase oxygen supply, particularly maybe to collateral vessels or smaller diseased arteries.
Okay, and pharmacokinetics really dictate how these are administered, right? Sublingual delivery bypasses that critical roadblock of first-pass metabolism in the liver.
Yes, nitroglycerin specifically undergoes significant rapid hepatic first-pass metabolism. If you just swallowed the tablet, very little active drug would actually reach the systemic circulation. That's why the sublingual route, tablet or spray, acting in under a minute, and the transdermal route, like a patch or ointment, are pretty much mandatory for effective nitroglycerin administration.
Isosorbide mononatrate is different, though. It sounds more user-friendly for long-term use.
Yes, isosorbide mononatrate is a bit different. It has high and reliable oral bioavailability plus a long duration of action, mainly because it's much more stable against that hepatic breakdown. It allows for reliable once or twice daily oral dosing for long-term maintenance therapy.
Let's really focus on the adverse effects and the central professional hurdle. Managing tolerance. This seems crucial for counseling.
Yeah, common adverse effects are pretty predictable consequences of generalized vasodilation. Severe headache is very common, facial flushing too. Postural hypotension, feeling dizzy when standing up, and reflex tachycardia can also happen. But the big hurdle is tachyphylaxis, or drug tolerance. If nitrates are administered continuously, the vascular smooth muscle rapidly loses its sensitivity, often within just 24 hours. The vessels basically stop responding to the drug.
And the solution requires strict adherence to the nitrate-free interval.
Absolutely essential. To restore that vascular sensitivity, we mandate a daily period of usually 10 to 12 hours without the drug. For stable angina, this interval typically occurs overnight because myocardial demand is naturally lowest during sleep.
But the sources reveal a critical nuance for Prinzmetal patients. They need to time that interval differently, don't they?
Yes, this is a high-level mastery point. Remember, Prinzmetal attacks are often worst in the early morning due to those high catecholamine levels. So if we made the Prinzmetal patient nitrate-free overnight, we'd leave them completely unprotected during their most vulnerable period. Therefore, for variant angina, the nitrate-free interval must be scheduled differently, usually for the late afternoon or early evening. This ensures peak drug coverage during the night and early morning hours when the risk of coronary spasm is highest. It's a subtle but vital difference.
Finally, that warning against combining nitrates with PDE5 inhibitors drugs like sildenafil, that needs to be emphasized heavily.
Oh, it's an absolute contraindication, full stop. No ambiguity there. PDE5 inhibitors work by inhibiting the enzyme that breaks down cGMP. Nitrates work by increasing cGMP production via NO. If you combine the two, you get a massive, synergistic, and sustained increase in cGMP levels. This leads to profound, dangerous, and sometimes fatal hypotension. This drug interaction requires explicit, serious patient counseling every single time.
Okay. Our final agent is ranolazine, a sodium channel blocker often used in those really challenging refractory cases. Its mechanism sounds highly precise and unlike anything else we've discussed.
Ranolazine acts primarily by inhibiting the late phase of the sodium current, which we call late AA. This current, which normally increases during ischemia, causes an accumulation of sodium inside the heart muscle cell. Now, because the sodium-calcium exchanger works to get rid of that excess sodium, it pumps sodium out but brings calcium in. This leads to excessive intracellular calcium overload during ischemia.
Okay. So by blocking that late, ranolazine prevents the downstream calcium overload.
Exactly. And this reduction in calcium overload has a critical functional benefit. It improves diastolic function. When a heart is ischemic, that excessive calcium causes the muscle wall to stiffen, preventing proper relaxation and filling during diastole, the resting phase. Ranolazine reduces that stiffness, allowing for better ventricular filling and reducing the pressure buildup within the heart. This translates to antianginal relief without major effects on heart rate or contractility.
Which makes it ideal for those patients already maxed out on VO blockers or CCBs who just can't tolerate further drops in heart rate or blood pressure.
It's the precision tool for that specific niche, exactly. It has both antianginal and some antiarrhythmic properties, offering flexibility.
However, the complexity of its metabolism demands intense professional scrutiny. This sounds like a potential minefield.
It is, yeah. This is ranolazine's Achilles heel, really. It's extensively metabolized in the liver, primarily via the CYP3A enzyme family, and also to a lesser extent CYP2D6. It's also a substrate of P-glycoprotein. Because CYP3A is involved in metabolizing countless other drugs, ranolazine has a huge potential for significant drug interactions. Strong CYP3A inhibitors, like certain antifungals, ketoconazole, or protease inhibitors used for HIV, can dramatically increase ranolazine concentrations, raising the risk of adverse effects. You have to be very careful with co-prescriptions.
And we also have to consider its impact on the cardiac electrical system.
Yes, ranolazine can prolong the QT interval on the ECG. Therefore, it is absolutely essential to avoid prescribing it alongside any other drug known to prolong the QT interval, things like certain antibiotics or psychiatric medications, because of the increased risk of a life-threatening arrhythmia called torsades de pointe.
And finally, that curious gender disparity noted in the sources, what's that about?
Yeah, it's interesting and frankly not fully understood. The antianginal effects, for reasons still being researched, appear to be significantly less pronounced in women compared to men. It just highlights a need for tailored, individualized treatment, really careful monitoring of efficacy once therapy is initiated, especially perhaps in female patients. Hashtag tag outro. So we have journeyed through the whole spectrum of ischemic heart disease today. We've differentiated the mechanisms, fixed obstruction versus dynamic vasospasm. We navigated the three clinical presentations: stable, unstable, and Prinzmetal. And we mapped out those 4 primary pharmacological strategies, really drilling down into the molecular mechanisms like the ONA1 selectivity, the dangers of short-acting CCBs and those ISA agents, that critical verapamil to amlodipine hemodynamic gradient, the necessary timing of the nitrate-free interval, and the specific role of ranolazine in improving diastolic function.
Yeah, and for the elite learner, the critical takeaway, I think, is this. Mastering angina management isn't just about memorizing a list of drugs. It's about deeply understanding the interplay between those 4 core hemodynamic variables: heart rate, blood pressure, preload, and contractility. And then adapting your drug choices to the patient's unique clinical context. You always have to ask, is the patient bradycardic? Do they have heart failure? Is their pain effort-induced, or is it vasospastic? Every single choice needs to be rationalized against those constraints.
Exactly. And perhaps a final thought to leave you with. If the primary goal of antianginal therapy is balancing oxygen supply and demand, and we acknowledge that reducing demand is often the fastest way to control symptoms, consider this. If a patient has suffered a prior myocardial infarction, which pharmacological strategy decreasing demand, like the blockers do so well, or increasing supply, like nitrates aim for, which one do you think provides the greater long-term reduction in mortality risk? And why might that be the case? Think carefully about the enduring, long-term remodeling effects on the heart muscle itself that sympathetic blockade, like from beta blockers, mitigates, versus simple vasodilation, which doesn't really address that underlying pathology in the same way. That difference, that's the kind of deeper thinking you need as you continue towards mastery.